Hello everyone, this is Professor Harkirat Bal. Welcome back. Today's topic is the use of psychotropic medications in special populations, specifically focusing on women's health, those who are either pregnant, planning to become pregnant, or currently breastfeeding. I will be presenting this topic through a fictional case study, which will help guide our discussion on the appropriate and safe use of psychotropic medications during pregnancy and lactation. So the main focus will be on client safety. So let's get started. All right. When we talk about patient safety, can our patient take uh, any medication when they're pregnant or during lactation? Well, the answer depends on the data that we have. Everything that we do in medicine is all about evidence-based practice. And we know that the data comes from the clinical trials, but pregnancy itself is usually an exclusion criteria for most of the clinical trials, and especially for the psychotropic medications. So it is it becomes very challenging to make decisions when you have a limited data regarding the adverse event of these medications, more specifically during pregnancy. So most of the information that we get is usually from pregnancy registries that are created by the manufacturers, and also from the practitioners' case reports. So we make decisions based off of these two, agencies, if you will, or entities. Now, remember the old pregnancy category that we used to use, category A, B, C, D, X. A was the safest and X was considered big no. For example, multivitamin or maybe folic acid was considered, part of category A, and alcohol or maybe dilantin was big no, so that would be category X. Now the problem with the old-fashioned pregnancy category was that it pretty much grouped these drugs into these 4 or 5 letters, if you will, and it becomes very difficult to individualize treatment for us, for the providers. They came up with a new rule, if you will, in 2015, and something that we call pregnancy and lactation labeling rule, that provides a new system of documenting adverse reactions with narrative. So it actually it forces or encourages, you can say, the pharmaceutical companies to give us some more information. This is not a perfect system, of course, but it's, in my opinion, it's better than what we used to have. One thing that they didn't do is they really didn't make it mandatory. It seems like for the new drugs, yes, the new drugs are required to use the PLLR system, but we still have some old drugs, and it seems like they're going to update the information in a few phases. So we are still using the old category, by the way. And one thing that I really liked about pregnancy and lactation labeling rule, that they added a new subsection called females and males reproductive potential, and this section talks about a need for pregnancy testing and contraception and so forth. So I got a screenshot of just a label from the new PLL rule, if you will. So here's the old category D, and recall that the category D simply tells you that studies in pregnant women have demonstrated a risk to the fetus. However, the benefit of the therapy may outweigh the potential risk. Now, take a look at the new rule here. See how extensive it is. It's really giving you more information, telling you what specific studies showed so that we can really have a discussion with our patients and make an informed collaborative approach decision, if you will. All right, so with that information, I'm going to present a case, and throughout the lecture, we will focus on this case, and we will see if we can use this case to really come up with option for this patient. So you have Amandeep Kaur. She's a 24-year-old Indian American female with gravida 1 para 0. So that means this is her first pregnancy. With a major depressive disorder, and she is on Paxil Paroxetine 20 milligram one time in the morning, and she's referred to your clinic by her OBGYN, and today her PHQ-9 score is 12. She has several questions for you regarding her medication. And my question to you is, what is your next step in the management? So these are the questions she has for you. First question is there any other medication approved by the FDA that is safe for me? So very good question. And then we will I think I have like 11 questions, 10 or 11 questions, and I'm going to show you all the questions first, and then we will talk about her case in a few minutes. Second question is, should I stop taking the prescribed medication? Is it safe for my child if I continue to take the medication throughout the pregnancy? If I cut down on the dosage or take it for a shorter period, will that mitigate the risk? If I continue with the medication, what is the overall harm? And I think that's a very important question. If I stop taking the medication, what is the overall harm? So she's asking for harm in both settings, if I stop taking it or if I continue. What is your medication of choice during pregnancy? We love that question. Patients usually ask that, so we'll see how we can answer this question. Is it better if I take something else, like over the counter or herbal instead? Is that safe? And number 9 is, will I be able to breastfeed my baby? That's very, very important, right? And do I have a right to an abortion? Especially if so she's suffering from major depression, and if she cannot stop taking the medication, she's asking if she has a right to an abortion. Am I a bad person for asking all these questions? So this is a really good question, right? So take a look at it and then see how you would respond to this patient. And of course, in a few minutes, I'm gonna present this case again, and then we'll talk about one question at a time. All right. So the first question is there any other medication approved by FDA that is safe for me or safer for me? And my answer would be no. In general, no psychotropic medication is considered safe during pregnancy. All meds will cross the placenta, and there's no psychotropic drug approved by FDA for use in pregnancy. Everything that we do is pretty much off-label, and that's okay. It's not illegal. It's, just one thing I do want to make a point. Just because something is approved by FDA does not mean that it's okay to give or prescribe to a patient. We still have to talk about risk versus benefit. And if something is not approved by FDA, that does not mean that we cannot prescribe that medication. So we have to be very, very careful how we present our information to our patients. Now, brexanolone is the only FDA-approved medication for postpartum depression, not for peripartum. So remember, it's after delivery, postpartum depression, and it's an IV drug that is given over 60 hours or so. I believe they're coming out with a PO drug by mouth for postpartum, so that'll be something neat. All right, so the moral of the story is no, there isn't any drug approved by FDA. So what do we do now? Should I stop taking the medication? Well, first of all, never stop taking the medication without provider's consultation. We have to tell our patients that is never a good idea. So what do you next? Well, you assess risk versus benefit. A risk benefit. So there's a double risk here, right? Risk to the mother, of course, and to our patient, and then now we have a child, fetus, and then what are the benefits? And the benefits are also benefiting the mother and the child as well. We'll talk about that in a minute. Is it safe for my child if I continue the medication during pregnancy? Well, like anything in medicine, it depends. It depends on our assessment. Does she have suicidal ideation or homicidal ideation? Postpartum depression or psychosis is a big concern. Um, Remember, the patient is saying, is it safe for my child? The answer might be yes if you have a client who is very unstable. I always tell my patient if mom is not well, the child is not gonna be well either. So we have to be very, very careful when we make these decisions. Number 4, if I cut down on the dosage or take it for a shorter period, will that mitigate the risk? Well, again, it really depends. It depends if the symptoms are managed or not. For example, let's say, I'll give you an example. Let's say that a patient was on 50 milligrams. This patient, let's say, or somebody else is on Zoloft 50 milligram. And they're asking you, should I cut down on the medication? I'll take just 25. Is that okay? Or I take it instead of taking it for let's say for I don't know, 7 months, 6 months, can I just take it for 3 months? Well, we don't know. It really depends on the symptoms of the patient. If let's say for this patient, let's say instead of taking 50 milligram, we tell them, okay, take 25, but if the symptoms are not managed with the 25, then we're really exposing the baby to 25 milligram of that medication, and on top of that, health of the baby is in danger because mom is not healthy. So if you're not helping, if 25 is, let's say, sub-therapeutic dose, and you're not really helping the mom, that means you're not helping the baby either, but you're giving a 25 milligram of unnecessary drug to the baby. So how is that beneficial? It doesn't make any sense. So you're really having a double exposure to the child. So that can't be a safe practice. So and in that situation, I would rather give a 50 milligram of Zoloft so that we can really justify risk versus benefit. So my answer will be it has to be appropriate. I think that's the best conversation, that any drug that is appropriate and you can justify by discussing risk versus benefit, that would be the right way of mitigating the risk. All right, so here it is. All right. Number 5 is, if I continue with the medication, what is the overall harm? And I really like that question because she's asking what is the total risk here, right? I would like to answer that question by dividing the total harm
in three categories, if you will. The first one would be teratogenicity. Any drug that can interfere in the development process of the organ within the utero is considered a teratogenic drug. CNS damage can occur within 2 to 4 weeks prior to client even knowing that she's pregnant. So for example, if you have a client on Dilantin maybe or valproic acid, and she doesn't know that she's pregnant, you can actually have serious damage. We'll talk about these two drugs in a few minutes or so, and more specifically valproic acid, how it is so important to be very, very careful in female. Any person who is planning to have a child or may have a child, in my opinion, we should pick something else other than Depakote. All right, second category would be neonatal adaptation syndrome. So what is NAS? Well, simply it is difficulty adjusting to life outside the womb, right? A child is going to have a difficulty adjusting. So for example, you have a situation where mom was on maybe SSRIs, or she was taking something for pain or something for anxiety like a benzodiazepine and so forth, and then the child is going to suffer, at least for the first few weeks or so, is going to have a difficulty adapting. Hopefully it's a temporary. And then the third one is something that we called neurobehavioral effect, and that is usually a long-term effect. Now we do not have enough data. There's limited data on that, and so limited data on what exactly is a long-term effect of these drugs to that child. And some people may argue on the concept of nature versus nurture. For example, is it really the drug um, um, that is responsible for this behavior, or is this the environment? For example, if you have, let's say, a client who was on ADHD medications, some kind of stimulant, let's say, throughout the pregnancy, or any other drug, you can say, let's say cocaine, or maybe, I don't know, um, Ativan. Now this child, of course, will have some impact. Cocaine is bad, and we know that, or any other maybe prescribed prescription drug may have a negative impact on this child. But how much is the environment? Can we really pinpoint overall mental health or overall behavior of a child? Can we really make that a connection back to the fact that when mom was pregnant, she was taking a medication, and this behavior is because of that? So see how you can really get in a situation where it becomes very complicated, and it becomes very difficult to make those connections that one drug can cause. Now, on the opposite hand, there are some studies on some drugs where there's a clear data that will give you a relationship. For example, again, valproic acid. There is enough data that when if mom were to take valproic acid during pregnancy, there's a clear brain damage. So there is a clear long-term effect on brain development if a mother was taking Depakote, let's say. So that would be a long-term effect, something that we call the neurobehavioral effect. So this is how I would answer this question. So then she's going to ask you a follow-up question. Well, if I stop taking the medication, what is the overall harm? Because in the previous slide, I pretty much scared her. I told her so many things that can go wrong with the baby, right? So of course she's gonna say, then should I stop taking the medication? Seems like it's not worth it, right? Well, this is also a difficult question to answer. So what the client is asking is pretty much, what is the risk of untreated illness right now, right? Well, lots of bad things can happen if medications are stopped, especially early on. Um, I don't know if you are familiar with a well-published case of Andrea Yates. She had a mental illness, and she was on a psychotropic medication, and she had 5 children, and then she had issues with hallucinations and so forth. It's a well-published case. You can take a look at it. But at one point, I believe her provider either decreased the medication or discontinued psychotropic medication and told her to focus on positive thinking and so forth. But she was hallucinating, and she ended up killing all of her 5 children. So there is a clear evidence of what a client can do when a client is not on correct medications or appropriate medications. So there is a clear harm of risk of untreated illness. Again, as I mentioned earlier, if mom is not well, then baby will not be well either. There was a study done by Cohn, a naturalistic study, that showed that about 70% relapse rate when the client stopped taking the medication, and that's pretty high, and 30% relapse rate when the client still continues on medication. So that tells you that there are changes in the metabolism of the drug during pregnancy that can affect a drug level. So in other words, medication needs to be monitored closely in each trimester, because the metabolism during pregnancy is going to change. So this is a very complicated question, and most of the time we are not able to stop the medications. All right. All right. So number 7 is, what is your medication of choice during pregnancy? Don't you love that question? Patient usually ask us, and the patient asks me even for diabetes and blood pressure medications and so forth, or antibiotic. And the answer is, well, it depends. There's no one drug that fits for all. It's highly individualized treatment, and then our job is really to develop a collaborative plan. And I tell my patient, the best medication for you is the one that's going to work for you. And then there's so many variables. For example, if you have a mild case of, let's say, depression, well, we can refer for psychotherapy. Versus if my client is pregnant and then she has acute psychosis, she would need medications. Most of my patients are actually suffering from acute psychosis. I do inpatient, and so for me, it's not possible for them not to be on medication. And of course, I prescribe psychotherapy as well, but I have to do medication. And then I sit down with my patients, and we develop a plan of care. Now, in my opinion, Zoloft for depression, at least, it seems to be a go-to drug, and rightfully so. Maybe Zoloft is considered very safe, and it has a lot of data. But again, if client, let's say, tells me that, oh no, I had Zoloft 5 years ago and I really didn't like it. It didn't help me, or I got so many side effects, then who cares if Zoloft is a safe during pregnancy? If patient is telling you that I never liked Zoloft, or I did not get a good response, then that medication is not good for her. So we have to develop, and the patient can try to convince you to pick a medication that you think is not safe, or not necessarily safe. But if the patient tells you that she did very well last time when she was pregnant, then I think we should try that, because again, that's the beauty about developing an individualized care plan. So, well, number 8, now she's asking, is it better if I take something over the counter or herbal instead? Is that safe? Um, so, well, again, it depends, right? Just because something is over the counter, that doesn't mean that it's safe. For example, let's say that I have a patient who takes, too many Benadryl a day, or maybe a NyQuil every night or so to manage her anxiety. So, Benadryl will calm her down, or whatever the case is. Well, I know that, too much Benadryl is not a good thing. I would rather prescribe her maybe low dose of SSRI, so that I can really monitor her, to manage her anxiety. And then I know that I can treat her anxiety better with SSRIs than having her to take NyQuil or Benadryl, which I have no control how much she's going to take. So the answer is, again, over the counter simply doesn't mean that it's safe. Another thing that people usually ask is about herbal, and my answer is, and of course, everything is, in moderation, and then you have a discussion with the patient, and then risk versus benefit. Herbal simply, if something is natural, that simply doesn't mean it's a safe. Now, one of the herbs that we see a lot is St. John's wort for depression, and we know that St. John's is this lovely flower over here, and it will increase your serotonin and then helps with the depression and so forth. But I always tell my patients, none of the supplements and herbs are monitored or regulated by FDA, so we really don't know how much you're taking. We can't control the dosages and so forth. I'm not necessarily saying it's unsafe, but I don't know how much you're taking. And especially if you're also taking prescribed medication, that any medication that will increase your serotonin level, like maybe you're taking something for migraine, let's say, those triptans, or maybe tramadol for pain. There's so many other medications that will actually increase your serotonin, so you can really have some side effect. So be very, very careful. All right. Another option, for over the counter, I tell my patient, do you want me to prescribe you something that is very natural and covered by your health insurance? And they get excited, and I grab my prescription pad, and I prescribe exercise, and they so that they understand the seriousness behind it, if you will. So exercise will actually increase your serotonin levels. So there are so many studies on that. Just, how we know the role of exercise in diabetes, right? When we eat and exercise, we actually increase the sensitivity of our peripheral tissues to insulin. So same thing with the depression, with the serotonin levels are increased when we exercise. So I highly recommend that. And of course, the role of healthy diet during pregnancy and during mental health is very well documented, and proper rest. Rest is also important. Another thing is psychotherapy, especially if symptoms are mild, and we can actually prescribe psychotherapy instead of psychopharmacology. And let's not forget the role of ECT, electroconvulsive therapy. We know that, at least in my opinion, it's superior than antidepressant medications. It's not a first line because it's not well, it's invasive. That's why, but pregnancy is not a contraindication for ECT, so do not hesitate to bring that option. All right. So number 9 is, she's asking, will I be able to breastfeed my baby? And I love this question because I highly encourage people, patients or clients or women in general, to breastfeed if possible. We know that and there are so many benefits, right? So I'm glad we're having this conversation with her. And my answer is, you know, making a decision on medication use during lactation is far more easier than the making decision to use a drug during pregnancy. Um, what happened is when a patient is pregnant, whatever medication she's taking, the chances of that medication to pass through placenta and reach to the baby blood system is significantly higher, and then pretty much 100% of the medication is um, can be measured in baby's serum, if you will. But that's not the case when the baby is out. Now these are two different bodies, and you're not gonna pass 100% of the drug via breast milk. A rule of thumb is that about 10%, or you can say less than 10%, is considered safe. Now, having said that, most of the antidepressant medications are considered safe because about less than 5% exposure is present in breast milk. So again, as I said, you can encourage your patients, let them know that these medications are safe. You can even use lithium during breastfeeding, but just to check the lab and monitor the baby very, very closely, and go from there. All right, we talked about this. So number 10 is, do I have a right to an abortion? And this is a very important question. Um, and my answer is, well, it depends on the state you live in, right? Um, I am in California, and we know that in California it is legal. As a healthcare providers, um, our focus really should be always on our patients, on our clients, not our on religious background or our political background. So when patient ask these sensitive questions, we should never uh, impose what we believe in. We should just listen to our patients and offer them the options and provide a safe environment for our clients to have these conversations. Our patients should really feel safe and comfortable talking to us, and there shouldn't be any fear that we are going to report to the agency or judge them and so forth. And number 11, the last question she has for you is, am I a bad person for asking all these questions? And you can, if you are sitting with this patient in the room, in the office, um, you can imagine the environment overall. She's having these conversations, and she's asking about abortion, and then asking about uh, should I take this medication, should I stop it, and the fact that she has a major depression disorder, and she's going back and forth. And then at this point, just imagine she has a teary eye, and then the overall face expressions are telling you that she's feeling guilty, and then she's questioning the fact that she's pregnant and the fact that she has a mental illness. And then you may have a client with a bipolar, with psychosis and so forth. So this is a genuine question. Am I being a bad person for asking all these questions? And then the answer is, of course not. As I mentioned earlier, that as a healthcare provider, we have to be, always non-judgmental. It takes a lot for a woman to even ask these type of questions. So please remain non-judgmental, and provide resources to our patients. All right, with that information, we will come back to the case study again in a few minutes. But what I'm going to do is real quick, I'm going to take a look at some specific drug or drug classification maybe, to give you some tips on some medications that are considered safe and some that you have to be very, very careful, so that you can have a big list of what to do and what not to do. So we will start with the antidepressant class first. We'll talk about SSRI, TCAs, and atypicals. So this is pretty much like FYI. I'm going to read a bunch of the information, but we will come back to the case study in a few minutes, I promise. So animal studies, we're talking about antidepressant medication. Remember, generally speaking, I told you, well, generally speaking, no medication is safe during pregnancy, right? So just keep that in mind. Every drug you have to be, very careful, risk versus benefit, right? But talking about antidepressant, animal studies did not suggest teratogenic effect for sertraline, which is Zoloft, or citalopram, and only at a toxic doses for citalopram. So there's an answer. It seems like Zoloft has a lot of data, a lot of safety data, because we are prescribing that a lot. All right. First trimester, fluoxetine use is associated with increased risk of cardiovascular malformation. So be very, very careful with fluoxetine, especially during first trimester. And we know this is the time when most of the organs are being developed. Paroxetine is linked to cardiac malformation. So you get ventricle, septal, and valve defect. So fluoxetine and paroxetine seems like not a good idea especially during first trimester. Consideration should be given to either continue paroxetine use or switch to another antidepressant. If you're able to discontinue altogether, that's always a good thing, right? So take a look at the patient. Can you stop the medication? And be very, very careful. You have to be very certain that yes, you can stop the medication. If you absolutely cannot, if the symptoms are going to come back, and it's going to be very, very difficult for us to manage those symptoms when they come back, especially when the client is pregnant, because you have so many hormonal imbalance at that time. So the risk of those symptoms are very high for the mom and for the baby as well. So if you absolutely cannot discontinue, switch to another agent. Again, for example, Zoloft. Okay, avoid a Paxil, which is a paroxetine, and duloxetine in pretty much in all trimesters. So not a good drug of choice during pregnancy. I'll talk about maybe Paxil again, but generally speaking, I do not use Paxil for a variety of other reasons. I avoid Paxil if I can. So especially during pregnancy, you have to be very, very careful. Okay, there's increased risk of a poor neonatal adaptation. Infants with a third trimester exposure to SRI or TCA should be monitored. So this is remember we talked about overall risk in 3 categories when I said number 1, number 2, number 3. And then the second actually, I said poor adaptation, remember. So this is one of the recommendation that be very, very careful with the SSRIs, because a child may struggle to adapt, and usually this is a temporary for a few weeks or so. All right, next we have is mood stabilizer. So the first one was antidepressant, now we have mood stabilizers. Now The treatment of bipolar disorder during pregnancy is very, very important. Remember, you have a client with a bipolar, depression and cycling towards mania. So the risk to the infant from uncontrolled bipolar disorder is greater than the potential drug effect in utero. So most of the time, we are going to continue with these medications. Now, in general, our carbamazepine and valproate, this is your Depakote valproic acid, should be avoided. I like to avoid this as much as possible in female population, especially in the first trimester because of the risk of malformation. And I do have some slides that will talk about these drugs separately, if you will, with some images. That way you can remember that. So just remember, generally speaking, we're gonna try our best not to use these two drugs. All right. So here it is. Carbamazepine is associated with the risk to the fetus, including congenital malformation, spinal bifida, and developmental delays. So take a look at the image, and hopefully you will remember that next time when you prescribe carbamazepine for bipolar disorders, or maybe for seizures, and then patient happened to be pregnant. So you have to be very, very careful with this drug. All right, so the next drug on the list is valproate acid, and this is your Depakote. These drugs may produce a congenital malformation, example, neural tube defect, at a very higher rate than any other drug in these categories. Now, other complications may include hepatic failure and hypoglycemia, and there's a long-term effect, like a low IQ, and a greater risk for ASD. Now, Depakote should not be used to treat women with bipolar disorder or epilepsy who are pregnant, who are planning to become pregnant. One thing I'll tell you that I like Depakote. I feel very comfortable. I prescribe this a lot for my male patients. With the female patients, I try my best to manage their symptoms with either maybe lithium or maybe sometimes like atypical antipsychotic, or combination of some other drugs or so. I try my best to avoid, but I do have, a few patients, I think 20 or 25 patients or so, female patients, I can say, who are on Depakote. I'm not gonna lie to you, but I let them know. I discuss with them the importance of either not getting pregnant, or at least let me know if there's any chance of pregnancy. And I usually tell them I should be the first one to find out that you're pregnant, way before you tell the baby's dad, if you will, to make a point that how serious it is for us to stop the medication. But rule of thumb is we really should avoid as much as possible for any person who has a uterus. We should avoid Depakote. And it's a good drug, again, for male patients. I use that a lot, but you have to be very, very careful. As I mentioned earlier, most of the damage occurs within the first few weeks or so, 2 to 4 weeks, and then the patient usually doesn't know at that time that she's pregnant. So you have to be very, very careful. All right, so next drug is the lithium. So lithium is, again, a great drug. I use this a lot. One of the best drugs that we have for bipolar disorder, especially if the client has a suicidal ideation. It gives us some protection, right? The problem with the lithium is that it should be gradually tapered off before conception. We try to avoid it during pregnancy if it's possible. So if you know that you have a client who's planning to get pregnant, we should taper them off slowly, right? But patients who experience severe and frequent episodes and who were well managed on lithium, and you cannot discontinue lithium, and then if you have made that decision that lithium needs to be carried throughout the pregnancy, then you have to be very, very careful and then do very control frequent monitoring. I am not saying that lithium cannot be prescribed during pregnancy. If possible, stop it. But if you have to continue, it is not acceptable is not a good word, but if you really need it, then you need it, because remember, these patients, they have a bipolar disorder. Okay, so what is the big problem with lithium? Well, lithium is teratogenic in a way that it passed through the placenta and can result in something that we call the Epstein anomaly. Look at the normal heart over here, and on the right atrium, look at the placement of a tricuspid valve right here, right? Now, a client who is on lithium during pregnancy, when lithium passed through the placenta, it will result in displacement of the tricuspid valve here. So look at how low the tricuspid valve is here in the right atrium as compared to the normal location over here. So you have a displacement, lower displacement of this valve, and that becomes a problem. So remember, Epstein anomaly, it's a very important concept with lithium. Now, another problem with lithium is that it requires, of course, blood monitoring. You have to have a therapeutic range. And if client must be on lithium, then increase additional monitoring, do a very tight control. We should involve maternal fetal medicine at that time for thorough anatomy exam scan, such as high resolution echocardiogram in the first 16 to 18 weeks or so. What can happen is, believe it or not, they can nowadays, it's so amazing that they can do in utero cardiac surgery repair before the child is even born. So that is why it's so important to have very frequent controlled monitoring when the client is on lithium, so that we can actually repair by doing surgery before the child is born. All right. Now, next drug is lamotrigine. Now, it's considered safe, to be honest with you, very safe drug. Generally speaking, it would be your drug of choice if the patient cannot be on lithium, or definitely cannot be on Depakote during pregnancy. Then go-to drug would be lamotrigine as a monotherapy, or even a combination with some other antipsychotic medication. I use like a atypical antipsychotic, let's say Abilify. Most of the time it's considered safe. One thing you have to be very careful with the lamotrigine is your skin rash. Can be dangerous, like a Steven Johnson syndrome type of rash, but that has nothing to do with the pregnancy, right? That rash, that a problem is there, whether or not a client is a male or female, she's pregnant or not. So that's nothing new. But other than that, this drug is considered pretty safe. All right. If the client becomes pregnant while taking trimethadone, termination of the pregnancy should be considered. So this is big no. All right, how about phenytoin, which is dilantin? Well, dilantin may be associated with neonatal coagulation defect that may cause bleeding during the early neonatal period. So keep an eye on that, and then we will use a vitamin K prophylactically. Also, parental exposure to dilantin is associated with a greater risk of neuroblastoma. So in general, risk of use of this class of the medication appears particularly high in the first trimester. If you have a client who's taking phenytoin, let's say for seizures instead of a bipolar disorder, then you have to be very careful, because abrupt discontinuation of this drug, may become a serious issue if the patient was taking it for seizures, let's say. Because you can only imagine if mother her seizures were controlled with this drug, and then somebody stopped this medication all of a sudden, and if mom is having seizures during pregnancy, you can only imagine the negative impact of that seizure on the child. All right. So that was all of your bipolar medications. We talked about lithium Depakote and some other drugs, and now we'll talk about antipsychotic medications, such as typical and atypical antipsychotics. So the risk associated with typical antipsychotics are minimal, and these drugs can be used safely during pregnancy. So your typical drugs are, such as like Haldol and so forth. However, of course, to minimize the risk of EPS, extrapyramidal side effect, you have to be very, very careful, because if you are prescribing, let's say, a typical drug, which I said is considered pretty safe, with the information, with the understanding that there's no drug that is considered safe during pregnancy, right? So let's say that you have a client on Haldol, or any antipsychotic medication. The dosage has to be accurate, because the other drugs that we give to control EPS are not considered safe, and they're actually harmful to the fetus. So you have to be very, very careful with the dosages. And again, we try our best to avoid as much as possible. We like to discontinue, but if you can't, then the dosage has to be appropriate dosage. And we know that the dosage should be appropriate all along, regardless if the patient is pregnant or not. There is a limited clinical data for the routine use of second generation antipsychotic medications. So if the patient must be on these agents, it is important to monitor both mother and the fetus very closely. A patient already being treated should not be switched from one antipsychotic class to other, because this may cause more fetal and maternal complications. So what I'm trying to say here is, as I mentioned, that the typical antipsychotics are considered safe, and here it says we have a limited data on the second generation antipsychotic. Remember, generally speaking, second generation antipsychotics are considered safe from metabolic side effect profile, right? But here we don't have enough data. So point we're trying to make here is that do not switch them to another antipsychotic just because we don't have enough data. If the symptoms are controlled with the drug that they're on, it's okay to continue as long as you're monitoring the patient very closely. This is really true a combination of science and art when we select a medication during pregnancy. General FDA warnings are that the third trimester exposure increase the risk for neonatal EPS or withdrawal symptoms. A child may have agitation, hyper or hypotonia, tremor, and so forth. Hopefully, these symptoms are transient and temporary and acute and go away. But it can the severity of these symptoms can vary from self-limited all the way to needing intensive care support and prolonged hospitalization for the child. So be very, very careful with that. All right. Well, what I'm going to do right now is I'm going to walk you through very quickly or briefly with a list of some common atypical antipsychotic that we use. The first one on the list is our clozapine, brand name Clozaril. Remember that this is a prototypical drug, a gold standard drug to treat schizophrenia, psychosis, and especially when you have a client who's who has failed other drugs, and especially when the client has suicidal ideations. This is a go-to drug. Remember, we talked about lithium. For bipolar patient, especially when the client makes suicidal ideations or has suicidal history, lithium was considered gold standard. So this is for your schizophrenia, if you will. This is a very good drug. However, it is not a first-line treatment because of the side effect profile, and more specifically, we talk about agranulocytosis. We check the WBCs, more specifically ANC, because the risk for infection is very, very high. Now, with that information, please understand that risk is the same. The risk does not change during pregnancy. So there's no other specific teratogenic effect or fetal toxicity that was observed in animal study. So again, it is considered safe. Well, kind of sort of safe. We know there's no safe medication during pregnancy, right? So, but if the client truly needs it, then we continue, but we just have to monitor CBC very closely. Remember, by the time the client is on Clozaril, that automatically tells you that the burden of that disease is so severe that it may not be possible for us to stop Clozaril. Otherwise, the patient wouldn't be on this heavy-duty drug to begin with, right? The second drug is quetiapine. I'm gonna do all the penes first, clozapine and quetiapine and so forth. Quetiapine can cause a lower fetal weight and delayed and skeletal ossification, so maybe not a good drug, if you will. Asenapine is a drug that may cause a lower weight and mortality in animal studies, especially when it was given more than maximum required human dose. That's what MRHD means. Olanzapine, which is a Zyprexa, has been associated with adverse pregnancy outcome, including neonatal death due to cardiovascular defect and abortion. So avoid this, not a good drug during pregnancy. If the client is not pregnant, this is a good drug. I prescribe this a lot of. I have a lot of patients on olanzapine, my go-to drug, pretty much, to be honest with you, but not during pregnancy, of course. Now, risperidone. So these are your penes, if you will: clozapine, quetiapine, asenapine, olanzapine. Now we will talk about some dones. The first one is a risperidol, as a brand name. Now, risperidol is an interesting drug. It's very like a dose dependent when it comes down to the side effect. When you have a low dose, like maybe 2 milligram twice a day or so, is pretty much atypical. And remember, atypical is your second generation. We consider second generation cleaner than the first generation, and especially from your metabolic side effect profile, if you will. But when you start increasing the medication dose, let's say you have a client with a 16 milligram, which is a max dose for risperidol, then that time the drug acts like a typical drug, like a Haldol and so forth. So something to keep an eye on. And it also increases your prolactin level. Rule of thumb is risperidol is considered safe, but be careful during lactation. We'll talk about that in a few minutes, about the lactation part. Geodon, ziprasidone, is a consider or associated with developmental delays and neurobehavioral impairment. There are no adequate and well-controlled studies in pregnant women. The rule of thumb is that in animal studies, when the dose is more than a required human dose was given, this drug caused cardiovascular malformations. Latuda, lorazepam, there's no teratogenic effect or fetal toxicity observed in animal study, so consider safe. So these are your dones, risperidone and your ziprasidone and lorazepam. Now we'll talk about Abilify aripiprazole. And remember, aripiprazole, generally speaking, is considered a very safe drug. Usually this drug is not sedating, so that might be a good thing depending on what you're trying to achieve. But there's an increased fetal death in animal studies, lower birth weight and skeletal abnormalities. I most likely we wouldn't do during let's say during pregnancy, but it is considered okay in lactation, if you will. So one thing we have to remember is just because a drug is not safe during pregnancy, that does not mean that the drug is not going to be safe or safer during lactation. So remember, those are two different concepts. All right, so next is beta blockers. Remember, we prescribe beta blockers, or at least I do a lot, to manage some of the EPS like akathisia and type of symptoms from which is a side effect of antipsychotic medications. Remember earlier I said that the antipsychotic medications are kind of sort of safer during pregnancy, but the side effect of those drugs are managed by the drugs, and they are not considered safe. And here's an example. A beta blocker, I use the propranolol a lot. So in an animal study, use of a propranolol at dosage more than recommended human dose MRHD caused embryo toxicity and neonatal toxicity. Even though there are no well-controlled studies in pregnant women, but in animal study there was an evidence. And there's also evidence of intrauterine growth retardation, small placentas, and congenital abnormalities in women who received propranolol during pregnancy. So again, I will not prescribe beta blocker for my patients. Atenolol use, especially in the second trimester, is associated with infants small for gestational age. And studies with the first trimesters are limited. All right, so next is benzodiazepine. Well, with the benzodiazepine, the good news is that these drugs are rarely a matter of urgency. So the first trimester exposure should almost always be avoided. However, you may have a client who really needed benzodiazepine for first few weeks or so, maybe because of uncontrolled anxiety or panic attack, or you may have a client who is taking benzodiazepine as a substance use and you are not aware of that, or maybe patient was taking benzo and then she didn't know that she was pregnant. So you may have a situation where a client is on benzodiazepine even though you were not aware of that, or you did not prescribe the medication. In animal studies, there's a data that suggests a risk for a teratogenic effect, malformation, and such as a cleft palate. So here's an image of cleft palate. Okay, hopefully you can appreciate that. In some patient, a clonazepam, which is a Klonopin, another type of benzodiazepine, some babies who were exposed to the drug at the end of pregnancy may have trouble breathing, poor circulation, and low muscle tone, something that we call a floppy baby syndrome. So here you can appreciate that here and then here as well. Another drug called temazepam can result in exencephaly, which is pretty much, it's rare, but it's anomaly in a way that you have a client with a malformation of the neural tube, with large amount of brain is protruding, the tissue is pretty much protruding out. So a client should be instructed to discontinue the drug as soon as possible, and especially if the client is planning to get pregnant, then these medication needs to be tapered off. All right. Next is sedative and hypnotic. In animal studies, there's no evidence of teratogenic effect of these drugs. Offsprings of rats exposed to the doses higher than MRHD showed some evidence of delayed ossification and decreased weight or survival in animal studies. And there were fewer adverse effects that have been found in rabbits. But there are no adequate or well-controlled studies in pregnant women, so use carefully. Cases of severe neonatal respiratory depression have been reported with zolpidem was used at the end of pregnancy, especially when the medication was taken with other CNS depressants. So that makes sense, right? Now, melatonin and low dose of magnesium is considered safe pretty much as a sedative, and I do recommend melatonin. Now, for nausea, vomiting, which becomes very a common issue, of course, as we know. The drug of choice for during nausea vomiting during pregnancy is diclegis. Diclegis is a drug, a combination of doxylamine and B6, vitamin B6, and considered very, very safe during pregnancy for nausea vomiting. Now, so everything that we talked so far was pretty much prescribed medication when the person really needs either antidepressant, antipsychotic, and plus minus benzodiazepine and so forth. Well, how about you have a client who's pregnant and using some kind of a substance, and that could be anything: smoking, alcohol, benzodiazepine, narcotics, and so forth. List goes on and on. Cocaine and marijuana. Now, as we know that there are so many risk factors for anybody who use substance use, and more specifically when the client is pregnant, the problem becomes even more complicated. So the most common risk factor that I have in front of you are listed: poverty, poor nutrition, exposure to violence or trauma, depression, anxiety, chronic pain. So you can only imagine the client has a chronic pain, and then use of narcotics and so forth, and some other psychological stressor, and then they see substance use as a coping mechanism, if you will. So screening is very, very important. I think that's the key. Anytime the client is pregnant, we should be assessing our patient use a different type of tool. If it's alcohol, then cage and so forth. And then once you are done with the assessment, then patient teaching, and then assess the impact of that substance use on the mother and on the pregnancy altogether, and then effect on the fetus, of course. Educate the client with the facts such as preterm birth, placenta abruption, a child with a low birth weight, or potential or consequences of miscarriages, stillbirth, and neonatal death. So it's very, very important to educate our patients who are pregnant and using some kind of substance use. So, okay, so let's come back to our case study. Remember earlier we talked about Amandeep. So Amandeep, so as a reminder, let's do a recap here. She's a 24-year-old Indian American female, gravida 1, para 0, with a major depressive disorder, and she's on paroxetine, Paxil 20 milligram in the morning. So she was referred to you by her either PCP or OBGYN, and today her PHQ-9 score is a 12, and she asked you all those questions. Remember the 11 questions that we saw earlier. So what is your next step in management? So I'm going to have you pause for a few seconds. Hopefully you already have a plan. You can pause this recording and see if you can help her with the information that you have received so far. All right, so her PHQ-9 score is 12. Any score between 10 to 14 suggests a moderate depression severity. So a patient should have a treatment plan ranging from a counseling, follow-up, and plus minus a pharmacotherapy. Now, the fact that she's pregnant and her score is a 12, and then remember she asked you, can I stop taking the medication, can I continue? And those are all good options, by the way. It really depends, during assessment, does she have suicidal ideation? So I know I just gave you a score of 12, but that doesn't tell you did she say yes to SI or not, right? But let's say that she's not suicidal, or she has no thoughts. But if she's really overall there's a negative impact, she has no energy and her appetite is poor, she's not able to really take care of herself, and she's pregnant, and then how she's going to take care of her baby. And remember, these are the risk factors for postpartum depression as well. So we have to treat a client who let me take a step back for a second. Any person, any female client who's pregnant is at risk for postpartum depression. But that risk factor is even higher if the patient has a history of depression or history of any kind of a mental illness. And on top of that, pregnancy is another risk factor. It's a stressor, believe it or not, for some clients. And she is currently depressed. So that means, in my opinion at least, we should treat her depression. We can definitely talk about counseling, and we can do psychotherapy as well. If the symptoms were very mild, let's say the PHQ-9 score was maybe, I don't know, 3 or 4 or 5, then perhaps we can say, well, let's stop the medication and see what happens. Or if she wasn't pregnant, then I might have considered to stop the medication. A rule of thumb, at least for me, is when I prescribe antidepressant medication, I usually keep that for at least 1 year or so, and then we talk about tapering down. What if you stop the medication prematurely, early enough, and if the symptoms were not resolved fully, or they were just semi-resolved, let's say you got like 80% or 60% effect from the antidepressant medication, and you stop the medication, then if the second time the symptoms come back, it becomes very, very difficult to treat those symptoms. So keep that information in mind. So the risk of untreated mood disorder during pregnancy are great enough to argue for pharmacotherapeutic treatment during pregnancy. We talked about that. The risk for relapse of depression is well described in patients who discontinue antidepressant medication early on, and is a major concern because it may result in increased risk of poor parental care and maternal fetal nutrition. So that becomes a big problem. So the client, her PCP, her OBGYN, and you as a psych mental health NP provider, you all have decided to continue SSRI. You said, okay, she is a good candidate and we're going to continue with SSRI. Remember, SSRI is our go-to treatment for depression anyways, regardless if the patient is pregnant or not. However, the fact that she is on paroxetine, and we talked about that earlier, that paroxetine is not a good drug of choice, especially during pregnancy. So what I would recommend at the end of the assessment is to change her prescription, switch paroxetine to maybe Zoloft, and she's on 20 milligram of Paxil. You can give 50 if you want to, or you can be just in the safer side. You can start with the 25 milligram. I am okay with that. This is a conversation that needs to happen with the patient, of course, but monitor her very closely, and then have her come back maybe in 2 weeks or so, and then we will go from there. All right. So in summary, psychiatric disorders are prevalent with the highest incident occurring at the onset of childbearing years in women, and untreated depression, psychosis, and mood disorders can have ill effect on both the patient and the infant. And however, pharmacotherapy also may cause a negative outcome for the baby, so you have to be very, very careful. As I mentioned earlier, it's a combination of a science and an art. Because of this, it's important for the patient taking psychotropic to have a thorough discussion with her healthcare providers about whether or not to continue or discontinue pharmacotherapy during pregnancy. It is important to weigh the risk and benefits of all treatment options during pregnancy. What we as a healthcare provider, what we should be doing with these patients are always offer options instead of telling them what to do. Sit down with them, listen to them. I always tell my students, listen to your patients. Your patients are giving you the diagnosis, they're giving you differentials, giving you diagnosis, and they're giving you the treatment plan. All we have to do is just listen to them. So create that individualized plan and document everything. Make sure you have a consent and document all that. At the end of the day, patient safety is very important. I think if I want to summarize today's lecture, it would be that number one, no drugs are considered safe during pregnancy, and on top of that, any drug can be prescribed as long as the patient is aware, and then you are aware of the adverse effect, if you will, and you can monitor those patients very closely. Then that's a beauty about developing individualized care plan. And I think that's all I have.
And as usual, if you have any follow-up questions, please do not hesitate to contact me. Thank you so much for your time.